Hi, my name is Sarah Adie, and I'm a cardiology pharmacist at University of Michigan. Today, I'll be discussing anticoagulation in patients with COVID-19. There are several ways in which the COVID-19 pandemic may affect the prevention and management of thrombotic and thromboembolic disease. Both direct effects of COVID-19 or the indirect effects of infection, such as through severe illness and hypoxia, may predispose patients to thrombotic events. Hemostatic abnormalities have also been extensively reported in these individuals. Additionally, the severe inflammatory response, critical illness, and underlying traditional risk factors may all predispose patients to thrombotic events similar to prior coronavirus outbreaks. Let's focus a little more on those hemostatic abnormalities. The most consistent hemostatic abnormalities with COVID-19 include mild thrombocytopenia and increased D-dimer levels, which have been associated with a higher risk of requiring mechanical ventilation, ICU admission, or death. Disease severity is variably associated with prolongation of the prothrombin time and international normalized ratio and thrombin time, and variably by a trend towards shortened activated partial thromboplastic time. Additionally, a recent study looked at 3 cases with severe COVID-19 and cerebral infarction, with one patient having a bilateral limb ischemia. All these patients had elevated antiphospholipid antibodies. However, the authors note that these antibodies can also rise transiently in patients with critical illness and various infections. So whether these antiphospholipid antibodies play a major role in the pathophysiology of thrombosis associated with COVID-19 requires further investigation. But what are the consequences of these hemostasis parameter abnormalities? Tate and colleagues assessed 183 patients with COVID-19, 21 of whom died. Among notable differences between patients who died and those who survived were increased levels of D-dimer and fibrin degradation products and PT prolongation. These hemostatic changes indicate some forms of coagulopathy that may predispose patients to thrombotic events. However, it is not known whether these hemostatic changes are a specific effect of COVID-19 or are a consequence of the cytokine storm that precipitates the onset of systemic inflammatory response syndrome as observed in other viral diseases. Knowing these differences, future research should focus on optimal anticoagulant monitoring parameters for COVID-19 patients receiving unfractionated heparin. If the APT is low in these patients, adjustments to heparin dosing to reach therapeutic levels may result in over-anticoagulation. Some institutions use anti-10A levels to monitor heparin. Currently, the impact on these levels is unknown, though currently at Michigan we've had some alterations in anti-10A levels in our COVID-19 patients receiving heparin. However, current guidance from the Anticoagulation Forum that was published recently does recommend using anti-10A instead of APTT for monitoring patients on unfractionated heparin. Prophylaxis is especially important in these patients considering the incidence of thrombotic events. A report from Milan, Italy reported 21% thrombotic incidence, with the majority of cases occurring in ICU patients. All ICU patients received thromboprophylaxis with low molecular weight heparin. 75% of patients on the general floors received thromboprophylaxis. Similarly, a retrospective study from China among 81 patients with severe COVID admitted to the ICU, 25% developed incident VTE. Notably, none of these patients received VTE prophylaxis. In a study of 184 patients with severe COVID-19 from 3 academic medical centers in the Netherlands, there was a 31% incidence of VTE. All patients received pharmacological prophylaxis, yet underdosing was reported in 2 of the 3 participating centers. Notably, these values are much higher than the rate of symptomatic VTE events observed in thromboprophylaxis trials in medically ill population, which typically doesn't exceed 3% in patients not receiving anticoagulant therapy and less than 1% receiving thromboprophylaxis. Hospitalized patients with acute medical illness are at an increased risk of VTE. Hospitalized patients with COVID-19, we know are high risk, and a lot of them have other comorbidities or respiratory failure. They may be bedridden or requiring intensive care unit. So they should really be receiving pharmacological VTE prophylaxis unless contraindicated. However, one of the current controversies is, while we know these patients should be receiving pharmacological prophylaxis, what dose of pharmacological prophylaxis should they be receiving? Authors in the previous Netherlands study I mentioned also used an increased prophylaxis dose of low molecular weight heparin after 1 month of treating COVID-19 patients. The authors theorized that these increased doses may be required to overcome the dramatic elevations in levels of procoagulant factors that are not present in the standard post-op or hospitalized medically ill patient. Yet, due to the design of the study, the authors do admit that they could not adjust the findings for the actual administered doses of nadropirin, the low molecular weight heparin used in this study, or study the effect of the changes in the local protocols for thromboprophylaxis. Yet the authors suggest strict pharmacological thrombosis prophylaxis in all COVID-19 patients admitted to the ICU and suggest increasing the prophylactic dose in their wards, such as enoxaparin 40 milligrams twice daily, even in the absence of randomized evidence. Notably, the Anticoagulation Forum that I mentioned previously that was recently released also suggests using increased doses of VT prophylaxis in critically ill patients who are confirmed or highly suspected COVID-19 positive. These studies and these recommendations all suggest using heparin or low molecular weight heparin for thromboprophylaxis. Then we currently do not have a lot of data to guide us using prophylaxis with the new direct oral anticoagulants or DOACs. Though higher prophylactic doses were initially thought to be beneficial, results from the Inspiration trial may suggest otherwise. This trial aimed to evaluate the effects of intermediate dose versus standard dose prophylactic anticoagulation among patients with COVID-19 admitted to the ICU. It was a multi-center randomized trial with a 2x2 factorial design. Intermediate dose was enoxaparin 1 milligram per kilogram daily versus standard prophylactic therapy, which was enoxaparin 40 milligrams daily. The primary efficacy outcome was a composite of venous or arterial thrombosis, treatment with extracorporeal membrane oxygenation, or mortality within 30 days, assessed in randomized patients who met the eligibility criteria and received at least one dose of the assigned treatment. Among 600 randomized patients, 562 were included in the primary analysis. The primary efficacy outcome occurred in 126 patients in the intermediate dose group and 126 patients in the standard dose prophylaxis group. Based on this, the authors concluded that among patients admitted to the ICU with COVID-19, intermediate dose prophylactic anticoagulation compared with standard dose prophylactic anticoagulation did not result in a significant difference in the primary outcome of a composite of adjudicated venous or arterial thrombosis, treatment with extracorporeal membrane oxygenation, or mortality within 30 days. The results do not support the routine empirical use of intermediate dose prophylactic anticoagulation in unselected patients admitted to the ICU with COVID-19. We know there are several studies for VT prophylaxis in medically ill patients, including studies looking at extended prophylaxis in medically ill patients. Those listed here uses oral betrixaban and oral rivaroxaban for up to 45 days after hospitalization. In APEX, there was no significant difference between extended duration betrixaban and standard regimen of enoxaparin in the pre-specified primary outcome of a composite of asymptomatic proximal DVT and symptomatic VTE in acutely medically ill patients with an elevated D-dimer level. In Mariner, rivaroxaban given to medical patients for 45 days after hospital discharge was not associated with a significantly lower risk of symptomatic VTE and death due to VTE versus placebo. So what these studies tell us is they did not reduce the incidence of symptomatic VTE in medically ill patients when continued for several days after hospital discharge. However, the role of extended VT prophylaxis in patients with COVID is unknown. Some theorize that these patients may benefit given a lengthy disease course that may increase the likelihood of immobility. If these are used for extended VT prophylaxis, D-dimer should not be used alone, but consider a validated risk score such as IMPROVE from Mariner to help guide decision making. Notably, in Mariner, as listed on your right of your screen, they use this IMPROVE score 4 or more to choose patients who are eligible for rivaroxaban, or IMPROVE score 2, 3, and a D-dimer more than 2 times the upper limit of normal. However, while DOACs may be beneficial in that they don't have a lot of monitoring, some have theorized that heparin may be more beneficial in this patient population given its anti-inflammatory function, which led some authors to study the utilization in hospitalized COVID-19 patients. This was a retrospective study in about 450 patients, 99 of whom received heparin, for which the majority received low molecular weight heparin for 7 days or longer. The doses used are on the bottom right of your screen. The authors used a 6 score, which was based on the SOFA score along with the platelet count and INR. Notably, the authors found no difference in 28-day mortality between heparin users and non-users, but the 28-day mortality of heparin users was lower than non-users in patients with a 6 score of 4 or more, or a D-dimer over 6-fold the upper limit of normal. Notably, the authors suggest to use anticoagulation, but if you look at this dosing, prophylactic dosing of low molecular weight heparin was used in most of the heparin users. So the outcomes of the study have led some to think we should be putting therapeutic anticoagulation on many of these patients if they have some of these risk factors. However, from the study, we can only really say prophylactic anticoagulation in these patients is probably beneficial, and we don't really know the role for empiric therapeutic anticoagulation at the moment. However, if patients do develop a VTE or we have high suspicion and we cannot test them, we do have some considerations for VTE medical treatment. This was a retrospective study in about 450 patients, 99 of whom received heparin, for which the majority received low molecular weight heparin for 7 days or longer. The doses used are on the bottom right of your screen. The authors used a 6 score, which was based on the SOFA score along with the platelet count and INR. Notably, the authors found no difference in 28-day mortality between heparin users and non-users, but the 28-day mortality of heparin users was lower than non-users in patients with a 6 score of 4 or more, or a D-dimer over 6-fold the upper limit of normal. Notably, the authors suggest to use anticoagulation, but if you look at this dosing, prophylactic dosing of low molecular weight heparin was used in most of the heparin users. So the outcomes of the study have led some to think we should be putting therapeutic anticoagulation on many of these patients if they have some of these risk factors. However, from the study, we can only really say prophylactic anticoagulation in these patients is probably beneficial, and we don't really know the role for empiric therapeutic anticoagulation at the moment. However, if patients do develop a VTE or we have high suspicion and we cannot test them, we do have some considerations for VTE medical treatment.
Given that evidence for therapeutic anticoagulation was all from observational studies, leaders of 3 randomized trials joined forces to determine the impact of therapeutic anticoagulation on outcomes. Adults hospitalized with COVID-19 were stratified by severity of their illness, either requiring ICU level care or not, and then randomized to receive therapeutic dose heparin or usual prophylaxis for venous thromboembolism, all according to local hospital policy. Patients were treated for 14 days or until hospital discharge, whichever came first. The primary outcome was the number of days free from the need for oxygen support, ICU level care or requirement for mechanical ventilation, extracorporeal membrane oxygenation, vasopressors, or high flow nasal oxygen through day 21, which also incorporate in-hospital mortality. As shown in the slide, a press release in December 2020 said that enrollment in the ICU stratum had been paused based on futility, though the trial continued in moderately ill patients. Shown on the slide are interim results, which showed conflicting results between those patients in the moderate state versus severe state. Patients in the non-ICU arm show benefit with therapeutic anticoagulation. It's unclear why full-dose anticoagulation would be beneficial in those moderately ill or in the moderate state, as shown on the slide, patients with COVID-19, and potentially harmful in those already in the ICU, though some hypothesize that it could have to do with timing of treatment. Notably, these are interim results and the data is not yet published, so it should be taken with a grain of salt. Because there is not currently good evidence to suggest either therapeutic anticoagulation or higher prophylactic doses of anticoagulation, two guideline bodies came out with recommendation, the NIH and ASH, as shown on the diagram, for prophylaxis in both acutely ill hospitalized patients with COVID-19, acutely ill being defined as just hospitalized patients, and then critically ill patients, which is on the bottom row with COVID-19. So notably, both guideline bodies recommend just using prophylactic intensity dosing in both populations over both therapeutic or higher prophylaxis doses. Until we have better data from the randomized controlled trials, it seems this is the best practice currently for these patients.
A selection of agent requires consideration of comorbidities such as renal or hepatic dysfunction, GI tract function, among others. Parenteral anticoagulation may be preferred in critically ill patients as it may be temporarily withheld and has no drug-drug interactions with investigational COVID-19 therapies. However, there are concerns with time to achieve therapeutic levels and increased healthcare worker exposure for frequent blood draws. Additionally, as mentioned previously, it may be difficult to ascertain if the levels are truly therapeutic if some of those hemostatic parameters are altered in these patients. Low molecular weight heparin may be used in those unlikely to need procedures, but renal function should be monitored closely and levels could be obtained if on for prolonged therapy. Additionally, dosing with obesity can get a little tricky, so that's where some of our levels may need to be obtained in that patient population. The benefit of DOACs include lack of need for monitoring, as well as the facilitation and discharge planning, but we should be cognizant of renal function and drug-drug interactions. For treating these patients, some are thinking that we should be treating them like a provoked VT or PE, so consider 3 months of treatment. But again, we don't have good guidance on the optimal duration at this time. Looking here at some potential drug interactions, on your left column are investigational COVID-19 therapies, and in the middle columns include warfarin as well as our newer direct oral anticoagulants and some considerations that we may need to take into our thought process when deciding the best agent for these patients. Some of the interactions include PGP inhibition. List of agents such as apixaban, rivaroxaban, we need to be concerned for CYP3A4 as well as PGP inhibition.
In summary, hospitalized patients with COVID-19 are at high thrombotic risk. VT prophylaxis should be utilized in all acutely ill patients with no contraindications, including those in the ICU. Unclear role at this time of empiric therapeutic anticoagulation, but hopefully we'll have the results of the trial that I mentioned soon. Consider using DOACs in eligible patients who do require anticoagulation for treatment of VTE in order to minimize monitoring.
Some of the ongoing studies are listed here, and they deal with many of the common themes we discussed today, such as therapeutic anticoagulation versus thromboprophylaxis, standard versus higher dose thromboprophylaxis, some of those viscoelastic parameters that we mentioned, as well as some novel things such as nebulized TPA for these patients. Thank you for your time today, and let me know if you have any questions.